Hi all. So welcome to the NEET-PG 2021 high yield MCQs on biochemistry. So with me, this is Dr. A. Balasubramanian, a biochemistry faculty. So let us first have a basic intro about biochemistry and its approach, MCQs and its approach. So mostly biochemistry is integrated to pharmacology as well as internal medicine. So these are our vertically integrated subject. Vertically integrated means it's going to be upside of your curriculum. So on top of your years. And then there is horizontal integration of biochemistry into anat and physio. This is a fellow preclinical subjects. So anatomy and physiology. So mostly our concepts will be aligned towards the concepts in pharmacology as well as medicine. So we learn about the biochemical processes which are happening here, and then we take it and apply to get the drugs for the biochemical processes, or we'll get to know about the disease processes in internal medicine. So this is how we are going to deal with biochemistry as such. And coming to the MCQs, solving MCQs is an art. As far as biochemistry MCQs are concerned, I suggest a specific oriented approach to you. We must divide the MCQs into three parts. The first part is going to be the pointer part. Pointers are something which are called as clues, which will give you a specific idea the exam question is going to expect from you. Okay, so these are the clues which has to be picked up from the question in order to derive at an answer. Never guess an answer. There is no possibility of getting an answer correct when you are guessing. It's all luck. There is nothing luck. It's all has to be systematically worked out. Okay, so make sure that you got the clues correct, and then there are something which are specifically vehemently placed in the question, which are called as distractors. The distractors are meant to deviate you from the central focus of the question, and they'll push you towards getting or selecting the wrong answer. Mostly the human mind picks up the distractors better than the pointers. Okay, so the distractors appear more juicy to the eye than the pointers. So you have to, this point of selecting between the pointers and distractors comes with repeated solving of MCQs. With repeated solvings of MCQs, you'll get the knack of how to isolate the pointers from the distractors. The final part is the stem of the question, or the stem of the MCQ. The stem is the question as such, along with the options which are focused towards the stem. Okay, so here most successful approach would be to isolate an option one by one. Okay, even it may appear that one option will be strikingly familiar to you, one option will be strikingly looking like the correct option. I would recommend that you take up each option and find out whether it is correct or not based upon your knowledge, and exclude the three options and then go for the right option. So all our discussions are going to be happening in this way only. So let us go ahead and start with the 10 MCQs. The 10 MCQs are going to be image-based MCQs. They are going to be clinical case oriented and picked up from all the 10 different chapters, so that you get a hang of all the things going on in biochemistry. Right. So let's start with question number 1. So a 1-year-old kid was brought to the OPD by parents with complaints of hypotonia. I will underline the important words here, pointers or distractors, whatever it is. So progressive dyspnea on feeding. So the child has hypotonia and progressive dyspnea on feeding. On examination, it was observed that the kid was having hepatomegaly and rales at both the lungs. Okay, so this is a very important pointer. Okay, hepatomegaly is going to be the very important pointer here. X-ray chest showed cardiomegaly. This is pointer number 2. This is 1 and pointer number 2. Okay, the muscle biopsy of the same patient is provided below. Select the wrong answer among the given options. Now this is going to be the distractor. Wrong answer. We need to select the wrong answer. There are 3 correct options and 1 is the right option. Now from the question you can see that the child is having hepatomegaly, the child is having cardiomegaly associated along with rales at base of both lungs. So this is a liver disorder which is manifesting along the cardiac lines. Okay, there is only one liver disorder which can manifest along with the cardiac lines. Let us go ahead and see the options, then we'll explain. The large vacuoles in biopsy are due to accumulation of glycogen particles. This is another clue. This is something related to glycogen. Okay. The enzyme deficient is lysosomal acid alpha glucosidase. Okay. The third is infantile form of the disease is lethal. Okay. The fourth one is the child is suffering from Tay-Sachs disease. by reading the question itself, most likely you will be able to pick up the answer. Even if you're not picking up the answer, the clue is given here. It's a liver disorder. It has to be linked with here. So this is going to be a glycogen storage disorder, right? So glycogen storage disorder. This is a very important point. 1 year old kid. So some glycogen storage disorder which manifest under 2 years along with cardiac manifestation. The answer is very, very simple. Okay, the disease is Pompe's. So this much should be easily this much should be easily obtained to you. The second option, look at the second option. The enzyme deficient is lysosomal alpha glucosidase. Of course, most of you would have learned that Pompe's disease is deficient acid maltase. Acid maltase is other name is the lysosomal alpha glucosidase. So that is going to be correct. So this one is correct. So this one is correct. Okay, infantile form of disease is lethal. This is little bit tricky. So Pompe's has 3 different variants. Okay, Pompe's has 3 different variants. Okay, so one is the first two forms are infantile. One is classic infantile. The other one is non-classic infantile. And then there is some adult variations. Okay, but both these are severe forms. Okay, both these are severe forms. Infantile form is very severe, results in death less than 2 years. And when we learn about an MCQ, we must learn about all the associated points along with that MCQ. As far as Pompe's is concerned, the gold standard of testing is DNA enzyme. Okay, the gold standard of testing is enzyme diagnostic. We go ahead and test for the enzyme deficiency. The other options will be DNA testing for mutations. The third option would be histochemistry, histology. This is the cheapest option. That's what is given in the slide. A picture of the muscle biopsy, glycogen molecules are seen. So that is exactly what the third option they have done. Okay, the treatment is very simple. It's ERT or enzyme replacement therapy. Okay, so give the acid deficient enzyme, acid maltase as lysosomal alpha glucosidase has to be administered, right? So now the fourth option, so this is also correct. Infantile form of disease is lethal. What about the fourth option? The fourth option, child is suffering from Tay-Sachs. Tay-Sachs is not glycogen storage. It comes under the mucopolysaccharidosis spectrum. So now with this question, you have to understand that 3 options are correct and 1 is incorrect. So which is the incorrect option? The incorrect option is option D. Okay, so I have given each option why it is wrong or why it is correct. I have given you the explanation. So you rule out all the 3 options and then you take up the whichever option is going to be the correct. So our references are here. We have given Harrison's as well as Harper. So you can always one MCQ read all the associated points along with that MCQ. That's end of question number 1. This is question number 2. A 13-year-old girl, this is all important. See, you must always remember the age has its own propensity to cause some diseases, okay? So a 13-year-old girl who was on treatment with sulfonamide for UTI, sulfur drugs, pointed number 2, sulfur drugs. She reported that the urine color has become more brownish and yellow eyes. Urine color has become more brownish. Okay, and yellow eyes. Okay, so this can only signify one thing. Okay, urine color has become more brownish. That means urine, more blood is getting excreted. That's why the darkening of the urine is there. And yellow eyes means she is getting icteric. There can be only one thing which can associate it with the darkening of urine and yellow eyes. That is called as hemolytic jaundice. Hemolytic jaundice. Okay, so there is a girl who has taken sulfur drugs and she is having hemolytic jaundice. That is what we have observed so far. Peripheral smear of this patient stained with methylene blue is shown below. Which of the statement is incorrect? So we have to go about incorrect statement. We are not choosing the right one. We are going to choose the incorrect statement. The labeled bodies are Haynes bodies. Okay, so this is you have to see that the Haynes bodies are this thing. So these are called as residual bodies, the Haynes bodies. This one. Yes, exactly. It has to look like this. Okay, central structure is that peripheral clearing with the dot. Okay, so that's how Haynes bodies look like. So this option is correct. Reduced activity of glucose 6-phosphate dehydrogenase can present in this fashion. So the question is, can G6PD decrease present like this. Of course, G6PD deficiency causes hemolysis. You all know that. So this is also correct. NADH deficiency leads to increased hemolysis and dark urine. At the outset, everything looks like very familiar. Oh, okay, fine. Increased hemolysis, dark urine, everything I have. Okay, so this also looks good. But there is a knack here. The problem is it's not NADH. G6PD has a pathology which is associated with NADPH. Okay, so this is a mild distractor. Supposedly, if you're not knowing this, then you'll get to land in a problem. These patients are resistant to malaria. Yes, they are resistant to malaria. Why they are resistant to malaria? Because the malarial parasite cannot survive in that erythrocyte. That is because this erythrocyte is prone for, it's a fragile, there cannot, because it's prone for hemolysis. Okay, so once the parasite goes into the RBC, the RBC is ruptured or RBC is undergoing hemolysis, the parasite is going to, not going to live here. So that is exactly the reason why these people are resistant to malaria, especially falciparum malaria. But you can't mug up NADH, NADPH. You need to know what is exactly happening here. Okay, so glucose is there. You all know that glucose is converted into glucose 6-phosphate. Okay, that's phosphorylation, first step of glycolysis, everybody knows. But then when you come to hexose monophosphate shunt, this glucose 6-phosphate is converted into 6-phosphogluconate. Now, this is where the enzyme G6PD occurs. Okay, supposedly there is a defect in this enzyme G6PD. It is going to raise the glucose 6-phosphate and it is going to decrease the 6-phosphogluconate. But the problem is not because of this substrate or this product. This G6PD, this conversion is needed to convert this NADP into NADPH. Okay, this NADPH is again needed to convert the glutathione into something called as reduced glutathione. Okay, now this reduced glutathione is needed for something called as detoxification of free radicals. Cell. Now, if there is no G6PD, there is no NADPH. There is no NADPH, there is no reduced glutathione. There is no reduced glutathione, there is no detoxification of free radicals, which means free radicals are going to be on the upside. These free radicals are going to go and destroy the RBCs. That is exactly the reason why the RBCs are prone to hemolysis. Okay, so what can we do here? We can limit the free radicals. Okay, there are certain conditions which lead to increased free radicals. Some conditions like taking sulfur drugs generate more free radicals, and then fava beans generates more free radicals. Then certain anti-malarial drugs. So basically, the conditions like this increase the free radicals. Already the body is struggling to clear the free radicals. These are the conditions in which free radicals are increased, means more and more free radicals and more hemolysis occurs and more disease process occurs. Now this is exactly what has happened with this girl. See here, she has taken sulfonamides. So she's already having a problem. Taking the sulfonamide, that's going to increase or accelerate the trouble here. Okay, hope this MCQ is clear now. Okay, so I've given all the explanations here. So each option, why it is wrong, everything I've explained you. Okay, this is a little bit simple. A 5-year-old boy, question number 3, visited Ophthal OPD with his parents. On examination, it was observed that he had white eyebrows and lashes. Most of you will come to the diagnosis here. So he has white eyebrows. In the picture, he has photophobia. Everybody is going to come into a conclusion. This is albinism. This is albinism. Which of the following statement is true? We are going for true statement. Okay. Defect in the synthesis of melatonin. Defective enzyme is tyrosine hydroxylase. Patients with phenylketonuria will have hypopigmentation. Defect in catecholamine synthesis are seen in these cases. This is, the options are a little bit confusing. Okay. So for some person who is not, who is reckless, okay, they'll go for directly this one. Okay. But the question is, there are 3 wrong options, 1 is the right option. We have to eliminate one by one. Number 1, defect in the synthesis of melatonin. It is wrong. The statement is wrong because albinism is associated with melanin. It is not associated with melatonin. So that's gone. Okay, we strike out one option. The defective enzyme is tyrosine hydroxylase. No, the problem here is the defective enzyme is tyrosinase. It is not tyrosine hydroxylase. We are dealing with a defective tyrosinase activity. Tyrosinase is an enzyme which is the pathway is the dopamine, all this melanochrome, everything. So it is going to give rise to melanin. So tyrosine hydroxylase is a different enzyme. If you know this point, this will also save you the fourth option. The same tyrosine hydroxylase is located in the adrenal medulla where the catecholamine synthesis is happening. So in tyrosine hydroxylase problem, adrenal catecholamine synthesis is decreased. So if this option is wrong, then this is also wrong. Tyrosinase has no problem with adrenal medulla or catecholamines. It is only located with the skin. Okay, so it's there in the skin, whereas tyrosine hydroxylase is located in the adrenal medulla. So option number 1 is wrong, option number 2 is wrong, option number 4 is wrong. So which of the following statement is true? The statement, whether by ruling out these 3 options itself, you can come to a conclusion with option C is the right answer. You can choose this. Or if you know the subject says that phenylalanine, which is an increased component in phenylketonuria, is a competitive inhibitor of tyrosinase enzyme. Competitive, na? Both are structurally similar. Okay, they're going to inhibit each other. Okay, so this phenylketonuria, what will happen is this phenylketonuria, phenylalanine concentration will be increased. This phenylalanine going to increase the inhibition on tyrosinase. Tyrosinase is a functional incapability of tyrosinase, which leads to a picture like tyrosinase deficiency and decreased melanin synthesis, which will be reflected as hypopigmentation. So always you must remember that phenylketonuria also presents like albinism in this point. That is because of the competitive inhibitive nature of phenylalanine on tyrosinase. So option C is going to be the answer. The references are given as below. All right, this is question number 4. Question number 4, oxygen dissociation curve for hemoglobin and myoglobin are shown below. Which among the following statements is false? Pretty much straightforward. Okay, so if you know the concept, you can get this question very, very, very easily. So concept is, just remember this point. Myoglobin increased affinity to oxygen. Why it is increased affinity? The hemo ion in the myoglobin is in Fe2+ state, but when it binds to oxygen, it will go to Fe3+ state. That will lead to more binding of oxygen. See, it is more positive. Oxygen exhibits negative charge, O2-. Okay, so it preferably binds to Fe3+ when compared to Fe2+. In hemoglobin, it's Fe2+. In myoglobin, it's Fe3+. So the oxygen prefers to go and bind to Fe3+ form of ion in the myoglobin. Okay. So what will happen is somebody is having more. You imagine like there are two fellows. Okay. Okay. So one girl has more love for. See, there is a girl called C. There is 2 boys, A and B. Okay. Right, so this girl has, both the fellows are loving the C, okay, but this girl has more affinity to A. So even the small acts done by the A will be exhibited more in case of in the girl's heart than when it comes to B. That is because the affinity is naturally more. So likewise, myoglobin takes up oxygen. This girl is like myoglobin. Okay, so this girl, myoglobin, gets takes up oxygen more when compared to hemoglobin. That means myoglobin is easily saturated with oxygen when compared to hemoglobin because affinity is more. So when particular amount of oxygen is available, myoglobin will go and tell, I will take up all the oxygen, I will take up all the oxygen. When compared to hemoglobin, when hemoglobin is struggling, myoglobin will easily take up and myoglobin will be filled with oxygen. So increased affinity, easy saturation. Okay, and third point, even at very low oxygen availability, even at very low O2 availability, myoglobin will be filled. Myoglobin will be filled with oxygen. That means there is an entity called as P50. P50 means the partial pressure of oxygen required so that a molecule will get 50% saturated with oxygen. Okay, now you can see that myoglobin is so much affinity is there to oxygen. Even at very low pressures, the myoglobin will get filled up with oxygen. With this backdrop, we will go to the question per se. See the options. Which is false is the question. So the first option, myoglobin has higher oxygen affinity at all PO2 values than hemoglobin. You know that this is the correct answer. I have explained you. Myoglobin releases oxygen at high oxygen tension. We will keep that. Okay. P50 is approximately 1 mmHg for myoglobin. See, option C and option D, even if you don't know the answer, if you are tricky enough, you can see the graph and you can derive the answer. Look at this. Somewhere, this is 50% saturation. And look at the value for myoglobin. It's very less, right? This is good. Okay. And look at the value for 50%, the same for hemoglobin. It is somewhere around here. So from this graph, the 50% saturation will come at 1, correct? That is correct for myoglobin. This is the graph for myoglobin. It will come at 26 for hemoglobin. So this is also correct. Look at the value. Look at the graph. It's coming somewhere around 26 here. So option 1 is correct. Option C is correct. Option D is correct. So the 3 options are correct irrevocably. That leaves us with option B, which is going to be the wrong answer. But you must know the reason. Myoglobin releases oxygen at high tension. No, myoglobin does not release oxygen. Myoglobin gets saturated. Myoglobin holds the oxygen. It is not going to release the oxygen at high oxygen tension, right? So the answer here is B, and every explanation has been given. The correct answer here is myoglobin release oxygen only under low oxygen tension. That is because it's like a concentration gradient. Very outside there is no oxygen, so myoglobin cannot hold. Even at that low oxygen also, myoglobin will comparatively hold more oxygen than the hemoglobin. Okay, remember this. Hemoglobin is to transport oxygen. Myoglobin is to store oxygen. Myoglobin will release the oxygen when there is oxygen deficiency in the muscle. So that is the low oxygen tension. Myoglobin will release. It will not release the oxygen in high oxygen tension. When you have more money, myoglobin will never give you money. When it's less, then myoglobin will give you. That is the concept behind this question. Hope all of you are getting clear. Okay, let's see the question. An young patient presents to a general physician with EC scarring. So this is point number 1, EC scarring. On examination, it was noted that the patient also had hyperextensible skin and hypermobile joints. So there is involvement of skin, there is involvement of joints, and all of the following mutations can cause this disease except. So from the question, we can find that this is some connective tissue disorder. Okay, so connective tissue disorders, basically they are involved in 3 pathologies. One is collagen disorders, second is elastin disorders, third is fibrillin disorders. Okay, so these are the 3 different connective tissue pathologies which can present with features something like this. And looking at the picture, this is a classic picture of something called as a EDS or Ehlers-Danlos syndrome. Okay. So if you go ahead and see, you can yourself Google for images for Ehlers-Danlos syndrome. So it will show you a picture of this particular picture of joints, and then some poses which will give hypermobile joint poses or something like that. But what I will say is, with basic facts, you cannot come to a diagnosis. But looking at the options are all located particularly in collagen disorders. Okay, so if you have that idea, you can come to a conclusion this is a collagen pathology which we are talking about. Okay, so before going into the details per se, let us go ahead and see what are the types of EDS. Okay, so when you see the pictures of EDS, search for images of EDS, you will always see a zebra picture along with that. Many people wonder what is the connection between the zebra and the Ehlers-Danlos syndrome. Actually, there is no connection per se between the two, but this condition is called as a medical zebra. Medical zebra means usually there is a saying when there are when you hear hoof beats, you think about horses but not zebras. Okay, so usually the professors say like that. That means never think about the rare and exotic diseases. Rather, you must always think about the common diseases that can present in your clinical practice. So people people are tuned to think for horses, but sometimes, rarely, zebras will also present like this. So that is why this is a very rare presentation disorder. So this is called as a medical zebra. Otherwise, nothing connected with zebra and EDS as such. We will go into the subtypes of EDS. This is considered to be one of the very difficult tabular columns, but let me make it try and make it simpler for you. Okay, so there are almost about 10 types of EDS. Okay, so but we will learn about 7, not all the 10. I will start with this, something like this. Okay, so here I will write the type. Next I will write the inheritance. Then I will write the defect, and probably here clinical features. All right, so let us go here. Type 1 and type 2 go together, and then we have type 3, then we have type 4. There is no type 5. Type 5 is non-existent. We have type 6 and we have type 7. In type 7 we have A and B together, CS together. So this is a subdivision here. There is a subdivision here. Okay. Okay. Now this type 1, I will give the nomenclature first so that you can easily understand. Type 1 and type 2 are called as classic EDS. Classic EDS. Okay. Type 3 is called as hypermobile EDS. Type 4 is called as vascular EDS. Type 5 non-existent. Type 6 is called as kyphoscoliotic EDS. Okay. Type 7 A and B is called as arthrocalcic EDS. Type C, 7C is called as dermatopraxis. Okay. Now, based upon this, we will write the clinical features. Everything is easy now. Okay. Okay. So, classic is involvement of skin, joints, and bones. Okay, skin, joints, and bones. Hypermobile, again, skin and joints. Hypermobile joints, hyper, everything is very hyper. Vascular is a serious one, arterial and uterus rupture. It may cause arterial rupture, uterus rupture, peritoneum might be involved, all these things. Okay, type 5 is non-existent. Kyphoscoliosis, again, spine. It involves the spine. Arthro, the word arthro involves joints. So 7A and B involves arthro. Dermatopraxis. Dermatopraxis involves skin, and in fact, this particular entity is called as cutis laxa. Particular entity is called as 7C is called as cutis laxa. Now, inheritance will come later. That is very easy. We will go for the defect. For type 1 and classic Ehlers-Danlos syndrome, 1 and 2 types, the defect lies in type 5 collagen. It's easy. Type 5 collagen. For type 3, the defect lies in something called as tenascin XB gene. Tenascin XB gene. This same tenascin X gene is also involved in the pathophysiology of congenital adrenal hyperplasia, CAH, adrenal glands. So there's another MCQ for you. So vascular, type 4. So type 4 Ehlers-Danlos syndrome associated with type 3 collagen. Okay. So kyphoscoliosis is an enzymatic defect, lysyl hydroxylase. See, lysyl hydroxylase is a copper-dependent enzyme which is involved in strengthening of the collagen tissues. When you read collagen metabolism, we will see how the procollagen, tropocollagen, everything is getting finally get all stitched together, put together for strengthening the collagen to get a final output of collagen molecule. So this lysyl hydroxylase has a important role to form in the formation of collagen output finally. Arthrocalcia, 7A and B, they are together involved. Defect is in type 1 collagen. Defect in type 1 collagen. Okay. Finally, dermatopraxis is defect in procollagen N peptidase. If you see this picture, this tabular column carefully. These two are enzymatic disorders. Okay, so both the enzymatic disorders will have autosomal recessive inheritance. Rest all of them will have autosomal dominant inheritance. If you try and mug this up, it is not going to work out. So rather you can remember like this: type 1 and 2 go together, classic. Okay, name alone you remember enough. Type 1 and 2 is classic, type 3 is hypermobile, type 4 is vascular, no type 5, type 6 is kyphoscoliotic, type 7, A and B put together is orthochalasia, type 7C is skin, dermatopraxis. Okay, if you remember this, and type 6 and 7C. See, 6 and 7C. Both are enzymatic disorders. Both are enzymatic. Okay, so rest all are autosomal dominant. Enzymatic both will come as autosomal recessive. Okay, so this much is the backdrop. Now we'll go to the question. So all of the following are true except, in this all of the following are true except, see, mutations in type 1 or 5. Obviously type 1 and 5. Type 5 is involved in the type 1 EDS. Type 1 is involved in the type 6. Okay, type 6 EDS. Okay, right, sorry, type 7 EDS. Mutation in lysyl hydroxylase, type 6 EDS. So that is also correct. How about mutation in tenascin XB gene? This is type 3 EDS. So if you see, it's very easily A, C, and D are correct options. What about elastin? Elastin is a defective. This is actually totally, it's a spectrum is different from the collagen disorder. So elastin will go along with the fibrillin. Elastin disorders are separate, fibrillin disorders are separate, collagen disorders are separate. What are the diseases? Elastin is Marfan, Burglar-Overreich syndrome, and number 3 is alpha-1 antitrypsin, emphysema. So these are all disorders which are pertaining to elastin defects as such. So the answer here would be option C, which is elastin defect. So otherwise this question is very easy. Everything else you can remember easily. The genes will be like the type 5 collagen, collagen 5A gene, type 3 collagen, collagen 3A gene, type 1 collagen, collagen 1A1 gene, like that. Okay, so you just have to remember the names, and once you remember the names, I think you can match with each other separately. So with this, we'll finish this question. We'll go for question number 6. An electrophotogram with densitometry scan is shown below. Identify the incorrect statement. Most of you will be familiar with this. Most of you will be familiar with electrophoresis. Okay, so an electrophoresis is the movement between a negatively charged field to a positively charged field. So we apply the sample here, and then the bands start running here. More the negative charge, more it will move towards the positive side, positive electrode. That is exactly the what the reason is. So the basic components of the sample are only 5 things. One is albumin. Okay, another one is alpha-1 proteins, and sometimes alpha-2 is insignificant. Then beta-1, beta-2, but mostly beta will put it together. Alpha-1, alpha-2 will separately show, but beta will put it together. Then there is gamma. Okay, among this, the basic consensus is albumin has the most negative charge, which means albumin will move farthest away from the point of application. Okay, so let us look at it here. Always remember, this is the point of application. So here, this is the point of application. The movement is happening like this. The movement is happening like this. So the thickest band is albumin. The thickest band is albumin, which means E is albumin. So identify the incorrect statement they are asking. So here we have the E is albumin. This is a correct statement. Okay. So next comes to albumin, alpha-1, alpha-2 bands. So this is albumin. Okay. Alpha-1, alpha-2. Okay. Right. No problem. C is alpha-1 globulins. B is beta globulins. B is beta globulins. Okay. That is also taken, accepted. And A is alpha-2, beta, A is gamma. Okay, now we have to identify the incorrect statement. Okay, so A is gamma globulin. Is that correct? A is gamma. That is correct. Okay, B is beta globulin. B is beta. Correct. Okay, no beta-1, beta-2. They are taken as beta. And then C is alpha-1 they have given. But what is C? C is alpha 2. So albumin alpha 1, alpha 2, beta, gamma. So albumin is E. Okay. Alpha 1 is D. Alpha 2 is C. Beta is B. And gamma is A. As per the diagram, it is there. But option says C is alpha 1. So this is correct, this is correct, this is correct. This is an incorrect option. So that is exactly what you have to find out. But in electrophoresis, other points important, everything is, what is that is, you need to know the patterns in two diseases, especially liver cirrhosis and nephrotic syndrome. In liver cirrhosis, what will happen is, there is something called as beta gamma fusion. The bands are so much, there is a defective production of proteins that the discrimination of the bands are not very clear. So the beta goes and overrides along with the gamma, leading to a beta gamma fusion or beta gamma bridging. This pattern you have to remember as far as liver cirrhosis is concerned. Nephrotic syndrome, you all know that nephrotic syndrome, albumin will be excreted. So the thickness of albumin band is less. Point number 1. Point number 2, in order to compensate for the decrease in albumin, the alpha 1 and alpha 2 will increase. So these bands will be thicker. So these points you have to know as far as the electrophoresis is concerned. The last point is, this is number 1, EPP, cirrhosis liver. This is number 2, EPP, nephrotic syndrome. This is number 3, everybody will know, EPP of multiple myeloma. Same thickness band like albumin in the gamma region. So albumin, albumin, this is there, na, gamma region, same thickness band like albumin. This is going to give a disease called as multiple myeloma. And this band is called as M band. This band is called as M band. So with that, this question is over. Question number 7. A child presented with blindness, anosmia, deafness, ataxia, ichthyosis, abnormal phytanic acid. That solves the question. Abnormal phytanic acid with typically short fingers and toes, as shown below. Which of the following statements about this disease is false? Okay. So phytanic acid has to be broken down by an enzyme called as phytanic acid hydroxylase. Phytanic acid hydroxylase. If this phytanic acid hydroxylase is not there, then there will be increased phytanic acid, which will lead, which is nothing but a very long chain fatty acid, and anything which accumulates in the body is going to present as a deleterious disease, right? So this disease in which phytanic acid hydroxylase is absent is called as Refsum's disease. So option number 1, they are asking us which is false. This patient is suffering from Refsum's disease. Yes, he is suffering from Refsum's disease. Enzyme deficient is phytanic acid hydroxylase. Yes, it is phytanic acid hydroxylase. And last options, mutations in gene encoding peroxin 7 receptor is responsible. Yes, this peroxin 7 receptor is responsible for causing deficient phytanic acid hydroxylase enzyme activity. This is a point to be remembered, peroxin 7. But look at option C, avoiding animal products is not helpful. The point which you must know is phytanic acid has certain precursors. Which are the precursors? Fish oils, dairy products, ruminant fats. You can look at this. All these are precursor for phytanic acid. When there is a problem in breaking down phytanic acid, we should stop phytanic acid from the diet. If you are going to give fish oils, dairy products or ruminant fats, it's going to increase the phytanic acid level. So the treatment is avoid the meat products, avoid the animal products. But here they have given avoiding animal products is not helpful. No, the treatment itself is avoid animal products. So how can that be a correct option? So this option is wrong, and that is why the answer is C. So this is a very straightforward question, but you should know the fact that phytanic acid deficiency is caused by peroxin 7, and then phytanic acid precursors are basically animal products. All right. Good. A 43-year-old man. Good. 43-year-old man. Family history of myocardial infarction. Family history is there. Good. A physical examination revealed Achilles tendon thickening, corneal arcus, and right carotid buoy. All these are important pointers. Which of the following statement is incorrect in this patient? Achilles tendon thickening. It is nothing but called as tendon xanthoma. This fellow has myocardial infarction. He has arcus senilis, corneal arcus, which means that lipids are getting deposited in the eye. Good. So this is a lipid disorder. Simple. The question is lipid. Right carotid buoy and heart problem. Heart problem. Okay, so basically, which could be by looking at the option, you will know that classification of disease. Probable diagnosis is familial lipoproteinemia type 2A. So they are asking us about lipoprotein disorder. It's very simple. There is only one lipoprotein disorder which has cardiac involvement, that is type 2A, which is otherwise called as familial hyperlipoproteinemia type 2A or familial hypercholesterolemia. Okay, familial hypercholesterolemia. Let's go to the option. Probable diagnosis is familial hyperlipoproteinemia type 2A, defect in LDL cholesterol receptor, plasma triglyceride concentration is normal in this patient, plasma total cholesterol in this patient is expected to be normal. So by this time you would have known the answer, but let me go ahead and explain some simple facts about hyperlipoproteinemia disorder. Okay, I'll make it very simple for you. Type 1 is there, type 2A is there, type 2B is there, type 3 is there, and then we have type 4, type 5. Most of the students tend to mug up this thing, but there is no need to mug up anything. Okay, it's very easy. Okay, so this is a defect. I will write this side, defect. Okay, and this is name, we will have name, and this is an increased product. Okay, so this increased product in type 1 is chylomicron. Okay, chylomicron. Type 2A, it is LDL. Type 2B, it is LDL and VLDL. Okay, if you understand the disease process, it is very important. Okay, it's very easy. Okay, in type 3, it is remnants, chylomicron remnants. So the names are always associated like this. Okay, I'm just writing it, I will explain this. So in type 4, it is VLDL. Okay, so type 5 is nothing but type 1 plus 4. So now we can easily write chylomicron plus VLDL. That's also a problem. Okay, now chylomicron is called as the exogenous triglyceride. That is, it comes from the diet, whereas VLDL is called as endogenous triglyceride. It is called as endogenous triglyceride. So some people call type 1 as exogenous triglyceridemia, familial exogenous triglyceridemia. Type 4 as familial endogenous triglyceridemia. Type 5 as familial mixed triglyceridemia. So basically, which is going to be increased is TGs in all these things. All right. Let's come to type 2A. In type 2A, there is a defect in the LDL receptor. Sorry, this is not ApoB, it's lipoprotein lipase. I'm sorry, lipoprotein lipase. Okay, fine. This is LDL receptor. Let's not discuss about type 2B. Let's keep it for as such. Okay, that is actually ApoB. But LDL receptor problem is there now. LDL receptors cannot take up the LDL. So what will happen is the LDL will be stuck in the blood itself. It is not uptake by the tissues. So more and more LDL will be increased, and this will reflect as a more and more cholesterol. When more and more LDL is accumulated in the blood, it will go to the heart and it will cause atherosclerosis. That is exactly the reason why this person has carotid bruit. Because of atherosclerosis, he has a family history of myocardial infarction, and this cholesterol will deposit in the tendons as tendon xanthomas. Tendon xanthomas. That is why he has Achilles tendon thickening. So this is the reason where this fellow is suffering from a type 2A disorder, and this is called as increased cholesterol disorder because of increased LDL. Familial hypercholesterolemia. This is called as familial hypercholesterolemia. Okay, I've told about in both these things, LDL and VLDL. This thing. Here we have increased something called as IDL or remnant. So this is always called as familial remnant disorder, or something somebody called as acetylcholine or something. Okay, so remnants defective ApoE. Remnants defective ApoE. Okay, and this 4 and 5 nothing. Decrease the catabolism of VLDL, decrease the catabolism of chylomicron and VLDL. Simple. Don't confuse anything. This is the reason. This is a table which you have to remember. Don't mug it up. It's very important that you understand the pathophysiology. Then only you can go ahead and you can give the answer straightforward. So here, if you see in type 2A, this is a patient with type 2A. Option number 4. Plasma total cholesterol is expected to be normal. How can it be expected to be normal? It is increased LDL, it is increased total cholesterol. That is the reason why we have all these manifestations. Okay, heart problem and all this. So if you know this concept, then you will have an answer to your question. All this is explained. Okay, this is good. Interesting question from enzymes. Okay, a graph is plotted to show the effect of substrate concentration on initial velocity of an enzyme catalyzed reaction. Okay, many people think that enzymes is a very dry topic. We cannot understand the enzymes, how to understand the enzymes. Okay, nothing. If you understand, then it's a very interesting and very easy topic. Okay, here they are asking identify the incorrect statement. Okay, if you don't have an idea of enzymes, you will never even touch this question. Nothing can be touched in this question because you don't understand what is happening here. Okay, but let me explain. There is something called as Michaelis-Menten kinetics. Point number 1, Michaelis-Menten kinetics is obeyed only by the regular enzymes. It is not obeyed by the allosteric enzymes. In order to know why, allos means other, steric na site. Okay, allosteric, I mean the word itself means other sites. Okay, Michaelis-Menten says that one enzyme should have one binding site in the substrate and it should have one catalytic site. All of them. That's all. Okay. Only that kind of enzymes will obey the Michaelis-Menten kinetics. Allosteric means there will be multiple sites for the enzyme to bind on the substrate. That kind of curve will be sigmoidal curve. It is same like that oxygen curve which you saw in hemoglobin. Okay, that curve is a sigmoidal curve. Wherever multiple binding occurs, wherever cooperative binding occurs, you will get the sigmoidal curve. You must remember this point. Otherwise, the enzymes will follow the Michaelis-Menten kinetics. Okay, now let us go, and I'm not going into the detail, but I will give you an equation. This is the equation which you have to remember for your life. Vi or V initial velocity is equal to Vmax S, Vmax into S substrate concentration divided by Km plus S. Now I am going to give 3 hypothetical scenarios. Okay, Km is greater than substrate, very much greater than substrate. Okay, Km is equal to substrate. Km is very less than substrate, that it can be ignored. Now let us submit these conditions into this equation and let us derive what is happening here. Km is very much greater than substrate. That means Km does not worry about the substrate at all. We will remove the substrate because substrate pales when compared to the Km. Okay, so what will happen at this time is, this is a constant. So Vi equal to Vmax divided by Km into substrate. So this is a constant, means Vi is directly proportional to substrate. This is scenario number 1. So when Km is greater than the substrate. Next is Km is equal to substrate. Now let us go again to the equation. Km plus substrate. So this says Km is equal to substrate. So let us write the equation here. Vmax S divided by Km plus substrate also I'm going to write as Km. Oh, sorry, substrate both I will write as substrate. Since Km is also substrate, equal to substrate, I will write both as substrate. So Vmax S divided by 2S. So both are the same. So Vi is equal to Vmax by 2. So Km is the substrate concentration at which velocity is at its half maximum. This is a definition given in your book. I have proven this definition now. Okay. The third option is Km is very much lesser than the substrate, which means we can neglect the Km. Km is nothing when compared to the substrate. So Vi is equal to Vmax S divided by Km. So Km we have taken, I am just taking. So, but it cannot be equal. I will just write as almost equal to Vmax. So this is exactly the question which has been asked in that question. Okay, I mean, this is exactly what they have asked in the question. So scenario 1, I just rephrase the scenarios just because the question has to resemble the scenarios. That is why it was a little bit confusing. But let's look here. Scenario number 1, which I have told you. See here, scenario number 1, Km is greater than the substrate concentration. Look at the graph. Substrate is here. Km is here. Km is greater than the substrate. So at this point, what I have told you, velocity is directly proportional to the substrate. Sorry. Velocity is directly proportional to the substrate. Okay, point number 2. Okay, at point B, velocity of the reaction is not directly proportional to S. Yes, it's not directly proportional because it's already attained the half maximal velocity. So point number 3, at point C, velocity of reaction is independent of substrate constant. There is no relation because already we have taken the substrate. I have cancelled the substrate, you can see. So it already reached a peak velocity or velocity maximum. That is exactly the reason why point C is also there. Then look at the point number 4. Hyperbolic curve is obtained when velocity is plotted against S for allosteric enzyme. So allosteric enzyme, we will not get hyperbolic curve, we will get the sigmoidal curve. I've told you that is because of the multiple binding sites. Michaelis-Menten obeying enzymes only will get the hyperbolic curve. Okay, so question number 9 is sorted for you. Okay, so the last option, last one, question number 10, a young child is presenting to the pediatric OPD with coarse facial features. Whenever you see the word coarse facial features, it is something related to the gangliosidosis or mucopolysaccharidosis, that kind of symptoms. Okay, psychomotor retardation. Histopathological examination of fibroblasts. They are looking at fibroblasts, shows the presence of inclusion bodies. Very simple, the diagnosis straight away given in the question. Identify the incorrect statement. When something shows the inclusion body in the fibroblast, then the disease is inclusion cell disease. Disease is inclusion cell disease. Okay, let me explain here. Okay, I will explain this. Let me use this this thing. So what happens in entire molecular biology? In entire molecular biology, the sigma, the doctrine, ignore this thing, we'll use this side. The doctrine is DNA has information, multiplies to more DNA, it gives rise to RNA. This process is replication, this is transcription. RNA will give rise to protein. You all know this, this is translation. Okay, you all know this, but many of you don't know what will happen to the protein after it has been synthesized. Once the protein is synthesized, this protein is taken to an organelle called as Golgi body. Golgi body is an organelle which will sort and package the proteins. It will sort and package the proteins. Okay, so it is like an Amazon center which will deliver. So Amazon center will receive your products from somewhere and it will put the label on that and it will send to the destination. Okay, like that Golgi body. Okay, if the Golgi body is not able to sort, it will secrete just the proteins into the excrete into outside the cell. Excrete outside the cell. Now you will ask, what is the sorting and packaging, sir? Sorting and packaging, they will add either O's residues or N residues. That and all I'm not going to, sir. Something called as protein targeting will happen. Protein targeting means that specific protein will be branded to go and go into the lysosomes. Okay, these lysosomes are the places where all the excretory products come: oligosaccharides, fats, proteins, amino acids, everything. So these proteins, certain proteins called as hydrolases, proteins or enzymes, hydrolases, has to be branded by the Golgi body to go into the lysosomes. This is the usual, but in a particular, how the branding will happen, sir? See, supposedly you have to send a letter to someone, you have to write the address. In address, a pin code is important. Now, supposedly you are sending it to me, Chennai, then it is 6 lakhs pin code. Like that, the proteins also have a pin code. That pin code is called as mannose 6-phosphate. There is an enzyme to put this pin code. N-glucose acetylamine transferase, one enzyme is there. So that enzyme will add this mannose 6-phosphate to all the proteins. The proteins will be branded to go and target the lysosomes. Once inside the lysosomes, they will clear all the oligosaccharides, amino acids, everything they will clear. But what if there is a defective branding? What if the enzyme is defective? What if there is no mannose 6-phosphate available? Then the proteins cannot be labeled. When the proteins cannot be labeled, these proteins cannot be able to enter the lysosome. Rather, they will go and secreted outside the cell. So these proteins will not enter the lysosomes. So the products will not be catabolized. So all the products are going to accumulate inside the lysosome. These are called as inclusion bodies. These are called as inclusion bodies. Now let us come to the question. This is a protein targeting defect. Correct answer. The child is leave the second option. Mutations in gene encoding N-acetyl glucosamine phosphoryltransferase, which is very correct. Absence of mannose-6-phosphate signal for lysosomal localization of correct. So 3 options are correct. The only option is child is suffering from Zellweger syndrome. Child is not suffering from Zellweger syndrome. Child is suffering from protein targeting defect called as inclusion cell bodies. Okay, Zellweger syndrome is absent functional peroxisomal defect. The peroxisomes catalyzing the peroxides is defective. That is a Zellweger syndrome. Okay, so the answers are explained as such. So everything is there for you. So with this, I have finished all the 10 MCQs. Hope you are all able to get the knack of how to solve the MCQs as such. So thank you all for spending your time with me. Hope you have had a great lesson, and God bless you. Have a great exam, and wish you all the very best for securing ranks of your choice. Thank you.